The purpose of this segment is to teach you how to use the Emergency Severity Index. I will review the algorithm in detail and will incorporate case examples to clarify important points. At the end of this segment, you should be able to use ESI to classify any patient that presents to your emergency department. Following this segment, you will have the opportunity to apply what you have learned to patient scenarios. The Emergency Severity Index uses both acuity and expected resource consumption to determine triage priority. Acuity or severity of illness or injury is used to assess the ABCs: airway, breathing, and circulation. The triage nurse evaluates the potential for life, limb, or organ threat to determine how soon that patient needs to be seen. Acuity is always assessed initially. After determining there is no immediate life threat, expected resource consumption is evaluated. Based on the patient's chief complaint and brief triage assessment, the triage nurse estimates the number of resources a patient is expected to consume in order for a disposition decision to be reached. In other words, what is it going to take to get this patient out of the emergency department, whether that is admitted, discharged, or transferred. I will talk more about resources later in this segment. ESI is a 5-level triage system. Each of the levels is clearly defined and mutually exclusive. A patient can't be a little bit of this and a little bit of that. They must be assigned to one level. There are no 3.5s. ESI allows for rapid sorting of patients upon presentation into one of these 5 levels. Triage using ESI differs from a complete assessment in respect to the amount of information that is obtained. For triage with ESI, only the information necessary to assign an ESI level is gathered. The triage nurse is gathering only enough subjective and objective information to assign a triage acuity rating. In this era of ED overcrowding, rapid sorting of triage is critical. A triage assessment should, on average, take between 2 and 5 minutes. As Paula stated earlier, triage data needs to be valid and reliable. One of the ways to ensure that this requirement is met is by having an experienced emergency department nurse at triage. A nurse who has attended an ESI educational program and whose competency has been validated. A triage nurse needs the knowledge and critical thinking skills to function effectively in this role and rapidly sort patients. An inexperienced triage nurse will make unsafe decisions with any triage system. To understand how ESI works, it is important to first look at the conceptual model of the algorithm. You will notice 4 decision points: A, B, C, and D. To use the algorithm, the triage nurse always starts with decision point A. Is this patient dying? If the answer is yes, the patient meets ESI Level 1 criteria. If the answer is no, the nurse moves on to decision point B. But let's look closely at decision point A. Is this patient dying? The criteria used to answer this question are: does this patient require immediate life-saving interventions? If the answer is yes, the patient is assigned ESI Level 1. What is meant by immediate life-saving intervention? Does this patient have an obstructed or partially obstructed airway? Are they unable to protect their own airway? Are they apneic? Or were they intubated prior to arriving at the hospital? Or does the triage nurse feel they need to be immediately intubated or placed on non-invasive ventilatory support because they were in severe respiratory distress? Or is their oxygen saturation less than 90%? Is this a patient who's pulseless? Is the triage nurse concerned that the pulse rate, rhythm, or quality is an immediate threat to life? Does the patient require immediate cardiac pacing, cardioversion, defibrillation, or immediate intravenous access and large amounts of fluid and blood given? Is this a patient who requires immediate medications to reverse a threat to life or limb? Does this patient have an acute change in mental status that requires immediate life-saving intervention? For example, are they hypoglycemic and require IV glucose? A heroin overdose who needs a reversal agent? A subarachnoid hemorrhage that cannot protect their own airway? For decision point A, the triage nurse is identifying the patient who on the AVPU scale meets the P or the U. A painful stimulus is required for response, or they are unresponsive. Any patient assigned to ESI Level 1 is physiologically unstable and requires immediate life-saving interventions. These patients need immediate care by both an emergency physician and one or more nurses. In some emergency departments, this may be a formal team response, like the code team or trauma team. The hospitalization rate for ESI Level 1 patients is very high. Most will be admitted to intensive care units. A few will die in the emergency department, and a few will be discharged or may leave against medical advice following treatment. Some examples of ESI Level 1 patients: a cardiac or respiratory arrest, an overdose with a respiratory rate of 8, someone in severe respiratory distress with agonal or gasping respirations, acute shortness of breath with an oxygen saturation of less than 90%, anaphylactic shock, a critically injured trauma patient, for example, a gunshot wound to the abdomen with a palpable blood pressure of 88, chest pain who's pale, diaphoretic, with a blood pressure of 90 palpable, patients with a chief complaint of dizziness with a recent loss of consciousness, presents with a heart rate of 40, patients with chest palpitations with a heart rate of 180, unresponsive with a strong odor of alcohol, severe stroke who needs airway protection. For each of these examples, the patient needs immediate, aggressive, life-saving interventions. The question is, will this intervention save this person's life? Interventions include intubation, surgical airway, continuous positive airway pressure or BiPAP, ventilation with a bag valve mask device, defibrillation, cardioversion, external pacing, chest needle decompression, significant volume replacement with crystalloid or colloid, immediate administration of medications such as vasopressors, glucose, and control of major arterial bleeding. There are many interventions that may be performed routinely in the emergency department for diagnostic and therapeutic purposes that are not life-saving. These include diagnostic tests such as an ECG, lab studies, administration of supplemental oxygen, placing the patient on a cardiac monitor, obtaining IV access, and the administration of medications that are important but not immediately life-saving. These may include aspirin, nitroglycerin, pain medications, antibiotics, and heparin. These interventions are not considered life-saving and do not meet Level 1 criteria. It is important to clearly understand the need for immediate life-saving interventions. If you do not, you will end up over-categorizing ESI Level 2 patients, and the meaning of ESI Level 1 will be lost. When you communicate with your physician and nurse colleagues that you have a patient that meets ESI Level 1 criteria, everyone will know that this is the sickest patient in the department, and both the doctor and the nurse should drop what they are doing. The patient requires immediate life-saving interventions that cannot be administered only by the nurse. This is not a patient that the nurse can put on the monitor, get a line, do a cardiogram, and then the doctor know about the patient. To summarize, decision point A, is this patient dying? If the answer is yes, the patient meets ESI Level 1 criteria. If the answer is no, the triage nurse moves on to decision point B. Is this a patient who shouldn't wait? There are 3 questions that the triage nurse needs to use to identify the patient who meets ESI Level 2 criteria. Is this a high-risk situation? Is this patient newly confused, lethargic, or disoriented? Is this patient in severe pain, distress? Let's look at each of these questions in more detail. Is this a high-risk situation? This is a situation where the triage nurse feels it would be unsafe for the patient to wait for more than a few minutes for a bed. The patient is presenting with symptoms of a condition that could easily deteriorate, or where the condition that's treatment is time-sensitive, or they have signs or symptoms of a condition that has the potential for major life or organ threat. Again, this is where the experienced triage nurse is so important. Using their knowledge of anatomy, physiology, pathophysiology, emergency medicine, and their clinical experience, the triage nurse uses their critical thinking skills to identify high-risk situations. The determination of high risk is based on a brief patient interview or on gross observations of the patient, or the triage nurse's sixth sense or intuition. Some examples of high-risk situations include the patient with a cardiac history who presents complaining of chest pain, who is physiologically stable. Rule out pulmonary embolus in a patient with multiple risk factors, again, physiologically stable. A newborn with a fever. We will discuss these criteria in detail later. Rule out ectopic pregnancy, neutropenia with a fever, suicidal, homicidal, a needle stick in a healthcare worker. Moving on, let's talk about, is this patient confused, lethargic, or disoriented? The triage nurse needs to identify the patient with an acute change in level of consciousness. Is this a situation where the brain is structurally or chemically compromised? The triage nurse has to determine that the patient is physiologically stable and does not require immediate life-saving interventions. Examples of new onset confusion, lethargy, or disorientation. Let's talk about those. New onset of confusion in the elderly patient. The family reports that this 86-year-old female is usually awake, alert, and oriented. She took a nap and now woke up confused. A 30-year-old with a known brain tumor whose wife reports that today he is confused. Or the adolescent who was found confused and disoriented. The third question with decision point B, is this patient in severe pain or distress? This is probably the most difficult concept for new users of ESI to fully understand. Many patients present to the emergency department complaining of pain, and so it is important for triage nurses to assess a patient's pain on presentation. Pain is a subjective phenomenon that has been defined as whatever the patient says it is. Triage nurses are required to assess and document a patient's pain upon presentation to the emergency department. Patients should be asked to rate their pain using a research-based pain intensity rating scale, such as the Visual Analog Scale or the Wong-Baker Faces. The triage nurse asks the patient if they are currently in pain. If the answer is yes, they are asked to rate their pain on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain you can imagine. How would you rate your pain? At the same time, the triage nurse is completing a brief triage assessment, asking about chief complaint, past medical history, medications, and allergies, and obtaining a set of vital signs. If the patient rates their pain as 7 out of 10 or greater, the triage nurse can assign the patient to ESI level 2, if and only if the triage nurse can do nothing to relieve their pain at triage, and the patient is in need of immediate interventions to relieve their pain. The test has to be whether the triage nurse would give their last open bed to this patient. Not every patient who rates their pain as 7 out of 10 or greater will be assigned to ESI level 2. For many patients, the nurse can provide comfort measures to relieve their pain, such as immobilization, ice, elevation, and distraction. In some EDs, the triage nurse works under triage protocols that provide for the administration of PO pain medication to certain patients. If the patient rates their pain as 9 out of 10, but has had the pain for a few days, is laughing at triage or eating chips, the nurse, in good conscience, will not give the patient the last open bed. Remember, it is the patient in severe pain that cannot be addressed at triage who will be given your last open bed. Patients who would meet this criteria include the patient with a suspected or known kidney stone who cannot sit still, who is nauseous, and needs IV pain medication, the patient with a severe burn, the oncology patient whose pain regimen is no longer working and they present to the emergency department for pain management, the patient with a possible dislocated shoulder who is crying, diaphoretic, and clearly in excruciating pain, the patient with a suspected compartment syndrome. Let's move on and talk about distress. Any patient who is experiencing significant physiological or psychological distress should be assigned ESI Level 2. Some examples of this include a sexual assault victim, the combative patient, the homicidal or suicidal patient, the bipolar patient who is manic, the acute grief reaction, the known alcoholic with signs of minor head trauma. Frequently, the triage nurse struggles with assigning ESI Level 2 to any of the patients we have just mentioned. However, it is important not to get emotionally involved in this decision. All of the patients we have just discussed are indeed high risk. All of these patients need rapid assessment and close attention. And if they leave the ED, the triage nurse will be accountable for her decision. This is a good example of how triage category and process may differ. For example, you may assign a psychiatric patient ESI Level 2, but they may not be placed in an open bed for a period of time. But the triage nurse may have called for a security standby, notified your psychiatric liaison, or even initiate lab protocols. The patient remains high risk independent of when they are assigned a bed. Take credit for the high acuity of these patients. Finally, we must also discuss severe physiologic distress. Often patients in respiratory distress are triaged as ESI Level 2. The patient may not require immediate life-saving intervention, but timely intervention of oxygen may be required. In general, while there are no time definitions for ESI, it is ideal for all ESI Level 2 patients to be placed in a treatment area and evaluated by the emergency nurse within 10 minutes of arrival. We have covered high-risk situations, new-onset confusion, lethargy, and disorientation, and severe pain and/or distress. To review, the following patients meet ESI Level 2 criteria. The patient with a history of renal colic who presents with severe flank pain and is vomiting. There is nothing the triage nurse can do to relieve this patient's pain. They need to be seen and have an intravenous pain medication administered. A patient with severe burns to both arms. A patient with a shoulder dislocation who rates their pain as 10+ and is diaphoretic and tearful. A psychiatric patient who presents to the emergency department screaming obscenities, is in severe distress, and meets ESI Level 2 criteria. ESI Level 2 patients remain a high priority. The triage nurse and the emergency department staff should be working together to facilitate rapid placement of the patient into an open bed, which is not an easy situation in this era of emergency department overcrowding. Patients assigned to ESI Level 2 were identified by an experienced triage nurse as someone who shouldn't wait. With ESI version 3, about 25 to 35% of patients were identified as ESI Level 2. 50 to 60% of these patients were hospitalized, and many required intensive care or telemetry beds. So we've now addressed decision point A and B. Let's move on to decision point C. How many different resources will this patient consume? Research has demonstrated that experienced emergency department nurses are actually very good at predicting how many different types of resources a patient will consume. This is based on the standard of care for a given chief complaint or diagnosis. It is independent of the type of hospital, location of the hospital, physician on duty, or acuity of the department. Of course, there may be some regional variations in physician ordering. For example, in some areas of the country, routine X-raying of an injured toes may not be done. Instead, the patient may be treated based on the physical exam. Some institutions use the Ottawa ankle rules, others do not. Another example is rapid strep screens. In some areas, the patient is treated based on the history and physical. In other areas, a rapid strep screen will be done to confirm the diagnosis of a strep throat. All of these practice variations are okay, and triage will accurately represent your individual department's acuity mix. Let's look at the ESI decision point C. How many different resources will a patient consume? No resources is assigned ESI level 5. One resource, ESI level 4. Two or more resources, ESI level 3. This graph demonstrates the average number of resources that were actually consumed by patients for each of the 5 triage levels. The data demonstrates the average number of resources used decreased monotonically as a function of ESI level. ESI level 3 used more resources than ESI level 4. ESI level 4 used more than ESI level 5. The triage nurse needs to count the number of different resources a patient will consume. But what is and what is not a resource? If you look closely at the chart, we have identified these for you. You will also notice when looking at the algorithm, although you need to estimate required resources, you never have to count beyond 2. Lab is a resource, whether you do 1 blood test and a urine test or 2 blood tests. Whether you do 1 blood test and a culture, it still counts as lab, 1 resource. ECG is a resource. X-ray, whether you do 1 X-ray or 10 X-rays, it still counts as 1 resource. A CAT scan, an MRI, an ultrasound, an angiogram, each of those counts as a resource. When a patient comes to the emergency department, it is expected they will have a history and physical exam. So these are not resources. Their history and physical exam should be appropriate for their chief complaint. So if they have an eye complaint, they will have a slit lamp exam, not a resource. If the patient is female and presents with low abdominal pain, she will have a pelvic exam, not a resource, but part of the history and physical for that chief complaint. Point of care testing does not count as a resource. Examples include finger stick glucose or pregnancy tests done in the emergency department. Inserting a saline or heparin lock does not count as a resource, but the administration of intravenous fluid does count. The administration of IM or IV medications does count as a resource. The administration of PO medications does not count. Neither does giving a tetanus immunization or handling a patient's prescription refill. Specialty consults count as a resource. The patient who needs to see psychiatry will consume 1 resource, whereas the patient who needs to be seen by surgery and social service will use 2 resources. Emergency physicians, as part of their plan of care, may contact the patient's primary care physician by telephone. This does not count as a resource. Finally, let's look at procedures. Simple procedures such as inserting a urinary catheter or a nasogastric tube count as 1 resource each. Conscious sedation counts as 2 resources. Simple dressings and crutch walking, slings and splints do not count as resources. The ESI research team is asked many questions about this. Nurses comment that they take a lot of time and should be counted. Remember, we are talking about triage acuity rating, not a workload measure. And think, what if crutch walking counted? All those patients with a sprain would now be in ESI level 3. They would require an X-ray and crutch walking. By including everything we do, we lose the ability to discriminate among the large number of lower acuity patients. So don't worry about it. The definitions are there to provide standardization. You do not get to decide what is and what is not a resource. You must follow the algorithm. By doing this, you help maintain the reliability and validity of the algorithm. As I previously mentioned, patients who require no resources are assigned ESI Level 5. Let me give you some examples of this type of patient. A healthy 10-year-old with poison ivy. A healthy 52-year-old who ran out of his blood pressure medicine yesterday. A 22-year-old involved in a car accident 2 days ago and wants to be checked out. Nothing hurts. A 46-year-old with a cold. ESI Level 4 patients are also stable and can safely wait for hours to be seen. This is an ideal group of patients for mid-level providers to care for in a fast-track or express care setting. ESI Level 4 patients require a history and physical exam and consume one resource. Some examples of ESI Level 4 patients: a healthy 19-year-old with a sore throat and fever, one resource, a strep screen. A healthy 29-year-old with a UTI, denies vaginal discharge, one resource, lab. Needs a urine culture, and a urine pregnancy test, which together are one resource. A healthy 43-year-old with a stubbed toe. I think I broke it. One resource, an X-ray. If your facility does not routinely X-ray these patients, then the patient would be an ESI Level 5. A healthy 12-year-old with a minor thumb laceration, needs suturing, an ESI Level 4. Now let's move on to ESI Level 3, 30 to 40% of the patients seen in the emergency department. These patients require an in-depth evaluation and because of this have a long length of stay in the ED. These patients will require a minimum of 2 resources. You must then address decision point D. What are the patient's vital signs? The nurse needs to consider the vital signs when assigning triage acuity. Are they outside the accepted parameters for age? If they are outside of those parameters, the triage nurse can up-triage the patient to ESI Level 2. Vital signs outside the accepted parameters do not automatically up-triage a patient. Instead, the nurse should consider the vital signs and make a decision. This is a really important point to stress. The triage nurse does not have to up-triage every adult patient with a heart rate of 100 or greater. Decision point D also includes temperature for children less than 36 months. The ESI Triage Research Team is following the American College of Emergency Physicians practice guidelines. The infant 0 to 28 days brought to the emergency department for a fever of 38 degrees centigrade or 100.4 Fahrenheit. This baby should be assigned to at least ESI Level 2, regardless of how good they look or what the chief complaint was. If the neonate's condition on presentation suggests that they are in need of immediate life-saving interventions, they should be assigned to ESI Level 1. For the infant 1 to 3 months, the triage nurse should also consider assigning the baby to ESI Level 2 if their temperature is 38 degrees centigrade or 100.4 degrees Fahrenheit. For the 3-month to 36-month-old child with a temperature above 39 degrees centigrade or 102.2 Fahrenheit, the triage nurse should consider assigning to ESI Level 3 if, in addition to fever, their immunization history is incomplete or they have no obvious source of a fever. For the 24-month-old presenting to the ED with a fever of 103 and the mom reports the child sees a pediatrician regularly and woke up from a nap pulling on his ear, the child would be assigned to ESI Level 5. Let's review frequently asked questions. Do I have to upgrade a patient's triage level if the pain rating is 7 out of 10 or greater? The answer is no, you don't have to. Let's review some examples of patients who might be assigned ESI Level 3, 4, or 5 due to pain. ESI Level 3, the fractured ankle, abdominal pain, most migraines. ESI Level 4, the sprained ankle, a toe, the abscess. ESI level 5, a toothache. Do I have to upgrade the patient's triage level if their heart rate is 104? For the adult with a heart rate of 104, the triage nurse should consider this as part of the assessment. The patient does not have to be up-triaged to ESI level 2. If the patient is always confused, are they automatically assigned to ESI level 2? No. ESI level 2 is for those patients with a new onset confusion, lethargy, or disorientation. Does ESI identify time to reassessment for each triage level? No. ESI does not do this, and this is a key difference between ESI and other 5-level triage acuity rating systems. The ESI Triage Research Group has purposely not identified reassessment times, but has left that to individual emergency departments to incorporate into their triage policy. We urge you to use caution. In this era of ED overcrowding, it is very difficult for busy triage nurses to reassess patients at a set time when they are busy sorting patients on arrival to the ED. And one last frequently asked question, what do I do with ambulance patients? These patients should receive an ESI acuity score using the same criteria we have just discussed. What if I assign someone ESI level 2 and I can't get them back right away? This is a great question. As the triage nurse, you are required to identify the triage level. You are not accountable to place the patient. Some ESI level 2 patients, the psychiatric patient, may not be placed immediately according to your protocol, but their triage score is the same regardless of your policy. However, it is desirable that the rest of your level 2 patients be placed as quickly as possible. As possible is the key. You should never lower your triage category because you know the patient must wait. You must be able to accurately represent the acuity of each individual patient as well as your department case mix.